Hello, my name is Mohamed Basha, and today I'll be talking about gingival hyperplasia and orthodontic patients. My PI is Dr. Joseph Cheever. So first of all, we're gonna start by talking about the introduction. The aesthetic of the gingiva surroundings the teeth in the anterior region of the maxillary arch are affected mainly by their appearance. The equilibrium on the form of gingival tissues can be significantly impact the harmonious appearance of the natural or artificial dentition. Patients' increased demand for more aesthetically pleasing outcomes may influence their treatment choices. An ideal anterior appearance is provided by healthy periodontal tissues uh, devoid of inflammation. An increase in size of the gingiva is a hallmark of gingival enlargement, also known as gingival hyperplasia. Accurately identifying the cause of gingival hyperplasia is necessary for effective management. Some causative factors for gingival hyperplasia caused by orthodontic treatment were discussed by Colin and Pfeiffer, including mechanical irritation from bands, chemical irritation from cement, food buildup, and poor oral hygiene. The equilibrium between the microbial agent and the host immune response determine periodontal disease initial stage and developments. So now let's move on to talk about our objectives. There are different types of gingival hyperplasia which require different treatment regimen. Surgical and non-surgical treatment are frequently combined depending on the patient's need. The purpose of this literature review is to discuss the most recent information regarding the etiology of gingival hyperplasia in orthodontic patients and treatment methods. So our next section is going to be talking about our methods. When starting to gather information, it was important to ensure that we found studies that were appropriate for our topic. It was also important to make sure that previous studies had been done on this topic. In this section, we elaborate on our research strategy and selected studies. The following PECO was used: population being patient with gingival hyperplasia, intervention being orthodontic treatment, no comparison, and outcome being malocclusion. A comprehensive literature review was done using the following electronic database: Web of Science, PubMed, Cochrane, Medline, keywords: gingival hyperplasia and orthodontic, gingival hyperplasia and orthodontic intervention, and gingival enlargement. Were used to search for relevant articles from 2000 to 2004 in English only. The reference list obtained was reviewed by a principal investigator. The studies selected for this research met the inclusion criteria of a topic related to gingival hyperplasia and orthodontic interventions. The selection criteria required the articles to provide specific information about gingival hyperplasia and orthodontic treatment. Gingival hyperplasia is a multifactorial disease that occurs due to response to various stimuli as well as different host environment interactions. This paper discussed the cause of gingival hyperplasia and the current treatment and management methods for individuals suffering with gingival hyperplasia. Gingival hyperplasia usually occurs 1 to 2 months after orthodontic treatment. Many factors can aggravate gingival inflammation and cause gingival fibrosis and hypertrophy, such as reduced plaque control, chemical and physical stimulation, and adhesives, mechanical band stimulation, and food impaction. Although plaque is often believed to be the leading cause of gingival inflammation and hypertrophy, it has been reported that gingival hypertrophy also occurs in patients with good oral hygiene, suggesting that orthodontic force and periodontal remodeling may also be associated with gingival hypertrophy. For example, Serlin found that out of 22 fixed orthodontic patients, 15 developed gingival hypertrophy. The level of matrix metalproteinase MMP8 in these patients was significantly higher than in the standard orthodontic treatment group, no periodontal lesion in the later group. Based on these results, they believe that the increase in MMP level caused by orthodontic force may be one of the cause of gingival hypertrophy, but whether pure orthodontic power is a direct factor in gingival hypertrophy or still needs to be explored further. On the other hand, it was shown that a continuous low concentration of nickel ion stimulation in some orthodontic device is essential cause of gingival hypertrophy in orthodontic treatment. Nickel ions may stimulate the growth of epithelial cells and the proliferation of keratinocytes by inducing T lymphocytes to produce interferon and interleukin 2, 5, and 10, which may lead to gingival hypertrophy. Nickel ion release may be a time-dependent type 4 allergic reaction. And the chart on the left side show us the nickel concentration and the ability to stimulate the keratinocytes proliferation. And on the right side, we can see, like under a microscope, how the tissue looks in response to the stimulation by nickel ion. So now we talked about our next factor. Another factor that may be associated with occurrence of gingival enlargement is hormonal changes that occur during puberty. Sexual maturation during puberty is related to increased level of the steroid sex hormones. As a result, subclinical inflammatory changes may be modulate periodontal tissues to be more sensitive to small amount of plaque, and a hyperplastic reaction of the gingiva may occur. It has been revealed by literature review that dental plaque formation contributes to pathogenesis of gingivitis that eventually leads to gingival hyperplasia. It's a known fact that placing orthodontic appliance raises the amount of plaque accumulation that changes the subgingival ecosystem. All these changes push host cells to release several inflammatory cytokines that include interleukin beta, interleukin 6, interleukin 8, and several other growth factors like tumor growth factor, TGF, that result in an inflammatory response in periodontal tissues to such appliance. An increasing occurrence of gingival enlargement was observed as the length of orthodontic treatment increased, even after the adjustment for important cofactors. Patients using fixed orthodontic appliances for 1, 2, 3 years had a 20 to 28-fold increase for gingival enlargement. So now let's talk about prevention and treatment of gingival hypertrophy. To prevent gingival hypertrophy, besides responsible plaque control, careful diagnosis, and regular periodontal maintenance during orthodontic treatment are also needed. Prior to orthodontic treatment, detailed inquiries about patients' allergies, chairside oral hygiene, guidance, rational selection of orthodontic instruments, and careful removal of bonding material can effectively avoid gingival hypertrophy. Orthodontic patients with gingival hypertrophy should undergo standard periodontal treatment. In some patients, the problem can be eliminated partially or entirely if the gingival hypertrophy has not completely subsidized. If the gingival hypertrophy has not completely subsidized, gingivoplasty is required to restore the gingival shape to normal. Traditional scalpels, electric knives, or laser can remove hypertrophic gingival tissues. Use of an electrotome is simple and can stop bleeding at the same time, but it may cause some thermal damage to adjacent tissues, leading to delayed wound healing. Use of lasers has many advantages, such as analgesia, rapid hemostasis, antibacterial and anti-inflammatory effects, and the promotion of tissue healing. Thus, the use of oral soft tissue laser in gingivectomies and gingivoplasty is a possible choice, and actually it's the better choice because of what we mentioned. Now let's talk about our future directions. Orthodontic treatment is closely related to gingival tissue changes, and the two interact with each other. while paying attention to patients' orthodontic situation. Orthodontists should cooperate closely with periodontal doctors to monitor any periodontal changes prior to orthodontic treatment. And now, in conclusion, the aim of this paper was to provide a comprehensive review of current practices within orthodontics in relation to gingival hyperplasia. After going through numerous articles, it was found that periodontal risk factors should be assessed and prognostic judgment should be made to predict possible risks and provide effective prevention in addition to effective chairside oral instruction. Periodontal examination and maintenance should be performed regularly during orthodontic treatment, and periodontal problems should be assessed actively. There is still need to increase patient awareness of oral hygiene maintenance after treatment to ensure they maintain their high periodontal health. Orthodontists should strengthen interdisciplinary cooperation with the periodontal practitioners to achieve the best therapeutic effect. Further, longitudinal studies may elucidate the association between the use of fixed orthodontic appliance and gingival hyperplasia and how to prevent more effectively. So yeah, this was my paper, and thank you for listening.